Hello and welcome to a talk on cell adaptation. So, for you to better understand cell adaptation, you need to be able to remember the normal cell physiology. And the moment you remember the normal cell physiology, you will then be able to apply the basic science to pathology. And remembering maybe from your physiology, histology, like a normal cell, how it's limited in its metabolic function, range through differentiation and the likes. So a cell within its normal homeostatic range, it can adapt to physiological or pathological changes. A classic example for a physiological change or state that can cause adaptation for cells is pregnancy. Or even if you look at the normal uterine cycles and the whatsoever, the hypertrophy, the hyperplasia that is going to be there within the endometrium. Then for pathological states, you're thinking of disease that can cause changes or stress on your cells, right? So normally, if you have a cell, if you apply stress to the cell, the stress can lead to a cell adaptation, and cells are simply going to adapt for them to avoid cell death. So we're going to talk about cell injury in a separate talk, where now we're going to think about cell death. So if a cell fails to adapt, the next port of call is now cell injury. And when you have cell injury, you can have a reversible injury within the cell, which brings back the cell to the normal cell homeostatic function. Right. If you then have irreversible cell injury, now we'll talk about apoptosis and necrosis, which is the cell murder and the cell death. But for now, we want to look at cellular adaptations. And what really is cell adaptation? Cell adaptation is a reversible structural and functional response to physiological or pathological stimuli. Like I've alluded to, an example for physiological stimuli would be pregnancy. Then an example for pathology, you are thinking maybe cardiomyopathy, you have maybe dilated cardiomyopathy, something that you come to learn when you do your cardiovascular pathology, right? So you can have different adaptations or modifications in a cell. It can be morphology, metabolism, proliferation, volume. Examples that most of you guys know from maybe your preclinical, you can have a decrease in metabolic function associated with a decrease in size of the cell. That's atrophy. You can have a change in the morphological appearance of a cell. You are now thinking about things like metaplasia and the likes. You can have an increase in cell number, hyperplasia. You can have an increase in cell size and increased cell demands in metabolism, hypertrophy. Right? So all these are kind of modifications that we are going to talk about, going to form the basis or the core of cell adaptations. Right. So I did talk about this when I say that the cellular changes, you start off with the stress, which leads to cell adaptation. Once you have cell adaptation, if the cell has an inability to adapt, we can go to cell injury, and the cell injury can either be reversible, and if it's reversible, we are going back to a cell in its homeostatic position, or it can be irreversible, which now leads to cell death, which can be necrosis or apoptosis. These two are going to be quite different. We'll talk about this in the talk on cell injury, right? So we have various things that trigger cell adaptation, both from the pathological and the physiological. So maybe before we go far, there are 6 things that we normally talk about, which is atrophy, neoplasia, hyperplasia, hypertrophy, then you have metaplasia, right? Then you also then have dysplasia. The prefix dys means abnormal, and plasia it's a growth. So these triggers can be pathological or physiological, right? And for for those that we have, maybe the physiological, you can think about hormonal for the uterus. You can think about cytokines for and growth factors for maybe your blood physiology, if you remember. You can think about mechanical stimuli. But there again, things in pathology, they come in twos, threes, and sixes, whichever way you guys prefer to say it. So you have injurious stimuli, which can either be physical, chemical, genetic, immunological, nutritional, infectious, whatsoever, you name it. I won't give specific examples because that's a bit broad, right? But the point there is injury can lead to a lot of things, right? But to make life very, very easy for you, you need to divide these things into genetic and acquired, right? That's a smarter way of dividing your causes for all these into genetic and acquired, right? The acquired, you can then further subdivide it into hypoxia, you don't have oxygen, nutritional, you're thinking about deficiencies in protein or carbohydrates. You can have immunologic, where you think of immune complexes being deposited, for example, in a basement membrane, then you eat up the basement membrane. That's good pasture syndrome. Just an example that I'm giving. You can think about physical, you can think about chemical, you can even think about biological agents, the infections, the bacteria, and the likes. Right. Okay. So these are examples of cell adaptation. I won't necessarily talk about this. Maybe hyperplasia, hypertrophy. I told you that there's going to be an increase in cell number if it's hyperplasia, cell size if it's hypertrophy. Atrophy, there's decreased metabolism or decreased metabolic needs and a decrease in cell size. And the nature of the injurious stimuli will actually be decreased nutrients or decreased stimulation. You guys have done nerve and muscle or your neurophysiology, you do neuropathology. You have things like denervation atrophy, disuse atrophy. So if disuse atrophy or denervation atrophy, those are concepts being explained by these basics, right? Metaplasia, if you have chronic irritation, you want to change the morphology of a cell to better adapt to the prevailing chronic condition. But then again, metaplasia is actually reversible. Remember when I started, I said these are reversible adaptations or reversible changes, right? Then hypertrophy and hyperplasia may coexist. You guys must know this from histology of the uterus, right? So changes in cell volume. For this, you can talk about hypertrophy. And what's hypertrophy? Hypertrophy is basically an increase in cell volume. Layman terms, an increase in cell size. That's hypertrophy. And there are no new cells that are generally present as compared to hyperplasia. So when you think about hyperplasia, there is an increase in cell number, right? But hypertrophy, the basic definition for hypertrophy is an increase in the size of pre-existing cells, which leads to an increase in the size of the organ being affected. I can think about the heart. Right. There again, there is a concept of what we call permanent tissue. Permanent tissue, these are tissues which if you form them, the way they're going to adapt, they don't have stem cells to regenerate. So adaptation for them is going to be hypertrophy, not hyperplasia. An example I'll give is the heart. You can have a hypertrophy of cells in the heart, but you can't have hyperplasia because there are no stem cells for that. That's the sole reason why you think about someone who gets a heart attack or myocardial infarct, if we are using scientific terms, that infarct will basically be replaced by fibrous tissue because we can't generate new cardiac cells. So when you think about the cardiomyopathies or whatever, that there's going to be hypertrophy of the cells per se, not hyperplasia, right? Keep that in the back of your mind. right? So that's hypertrophy. There's just an increase in cell size, right? Etiology, increased functional demand. For example, you are overambitious, you're a boy, you like girls, you like or maybe like muscle. You go to the gym more than I don't know number of times per day. The increase in stress for that can lead to hypertrophy of skeletal muscle. Skeletal muscle is also a permanent tissue which cannot be regenerated, right? That's just an example. Other examples you can read through there. I would rather talk about the mechanisms that happen for us to have hypertrophy, right? So the mechanism is stimulus and organ dependent, meaning it's not going to be the same for all the organs, right? But the basis, what's governing hypertrophy is an increased production of proteins within the cell. Why do I need proteins? Pause and think about filaments that you talked about in histology or cell physiology, basically cell physiology. Think about the filaments that you had, intermediate filaments, blah, 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 microtubules and the likes. Think about those things. What are the constituents of those things? You had protein, right? So, for example, in the heart, right? We can have an increase in mechanical stretch, receptor signaling, or growth factors or whatever. Think about someone in heart failure, right, or are retaining a lot of fluid, right? It's just an example that I'm trying to give, but that's cardiac hypertrophy, right? So you maybe this diagram will help us. Would you have an increased workload on the heart, which is going to lead to stretch, or you have hormones or agonists that are going to stimulate receptors, or you have growth factors like your insulin, like growth factor 1. All these things are going to stimulate signal transduction pathways, and the signal transduction pathways are in such a way that they're going to increase transcription factors. The examples given there, not important to remember. Once you increase transcription factors, you're going to have an increase in the synthesis of contractile proteins. You're going to have an induction of embryonic and fetal genes. Why? Because the fetal heart probably works more and is better adapted. Then you can have an increase in production of growth factors, right? And this increase in production of growth factors are going out again to stimulate more and more signaling cascades, right? And this cardiac hypertrophy, for the purpose of MCQs, it is associated with a switch from adult contractile proteins to fetal contractile proteins here, right? Where you change the isoforms for whatever the myosin from the adult form to the fetal forms, right? Okay. What's written there. I won't talk about that. You can read through. Then we have atrophy. Atrophy, like I said, it's a decrease in the metabolism for a cell, and there's going to be a decrease in the size of the cell, and that subsequently leads to a decrease in the size of the organ. Right? Just the basic definition for atrophy. Right. Then it can either be physiologic or pathological. The same thing that we're going to talk about for hyperplasia. It can either be pathologic or physiologic. The results, there is a decrease in synthesis of proteins or maybe increased protein degradation. Right. So pathologic or pathological atrophy, yeah. This is where now we have a disease condition that leads to atrophy in an organ. For example, you may have say an endocrine malfunction, then you don't have hormones. The disease now leads to a decrease in hormones that are supposed to stimulate a certain organ. That decrease in hormones that are going to stimulate a certain organ will now lead to atrophy, for example, estrogen, whatever, for the breast, if as an example, the endometrium. Or you can have disuse atrophy. You're thinking about someone with peripheral nerve disease, not disuse, but not peripheral, like upper motor neuron lesion. You can have disuse atrophy, or you can have denervation atrophy for lower motor neuron lesion or peripheral nerve disease, leading to denervation atrophy. All these things, not using the muscle, will lead to a pathological atrophy. There can be ischemic atrophy where you don't have blood supply to a particular organ point, or you can even have inadequate nutrition. You're having a diet that is not protein rich, you become cachexic, or maybe you have a disease, say cancer. You can get cachexic again, or maybe pressure and the likes, chronic inflammation. I won't talk about that. But when you go back now to the physiological bits of atrophy. This is now where you're thinking about during embryology. It may not be important to remember now, but things like thymus, the notochord, those things, they involute in size. For example, remember the thymus involutes up until puberty and is just replaced by fatty tissue up until a point that it normally disappears. Right. Then atrophy normally occurs via apoptosis. Right. Okay. Then what else would I want to talk about here? So remember I said, okay, so all this comes back to the point that there is going to be a decrease in protein synthesis or an increase in protein degradation, right? And for you to have protein degradation from your normal biology or from cell physiology, it's done by the ubiquitin proteasome pathway, this one, right? And when you activate this ubiquitin proteasome pathway by nutrient deficiency or disease, this can lead to an increase in protein degradation, right? And when you have things like disuse of a muscle, you simply activate this ubiquitin ligases that are going to destroy whatever you want to destroy. That's the basic mechanism in which these things come about. Right. Okay, I want to talk about that. Okay. Then hyperplasia, it's an increase in the number of cells in the organ. And you will have an increase in organ size as well. But this hyperplasia, the stimuli can be the same as those in your, what we call it, in your hypertrophy. And hyperplasia can also be physiological or pathological, right? And most forms of pathological hyperplasia, they're going to be hormonal, or there will be problems with growth factors, right? Then the etiology, it can be physiological. For physiological, you have hormones and growth factors in play. For example, compensatory hyperplasia. Since you can see these examples here, I'll use another example. Think about those people with donated kidney, or you've done renal physiology before. The nephrons in the opposite kidney will somehow, maybe not nephrons, but maybe let's use the liver. The way the liver regenerates, the nephron example is a bit bad because it's going to be hypertrophy. But for liver regeneration, remember you can donate that small bit of a liver and it can regrow to the normal adult size. That's through an increase in cell number. through hyperplasia, right? That's why you need growth factors and hormones as your stimulating factors. Then that's pathological hyperplasia. You can think about human papilloma virus, quite topical when we talk about cervical cancer and other forms of cancer. And this can lead to warts. There can be genital warts, skin warts, and the likes, right? Or maybe bone marrow hyperplasia in cases of chronic anemia. You're trying to compensate for the decrease in oxygen supply. Let's say in a tissue, someone has had profuse bleeding. They get into shock, or there's an increase in tissue demand for oxygen and the likes, right? Okay, that's so for me to have hyperplasia, the point there, I need stem cells. Right. For hypertrophy, I don't need stem cells to be there. Right. So it's growth factor driven, but I need stem cells. It's hormonal driven, but I need stem cells. Oh no, I didn't want to go this far. Okay. All right. Then there is metaplasia, which is now the reversible change from one adult form of cell type or differentiated cell type to another form, basically changing morphological appearance of a cell in response to a change in or a new chronic stress which the cell that was there before is not normally adapted to. For example, there is Barrett's esophagus, which is a metaplasia from the squamous epithelium of the esophagus to an intestinal epithelium in the esophagus. Is better adapted to acids that are refluxing. So that's GERD, gastroesophageal reflux disease. Right? You can think about the smoking, which changes the pseudostratified columnar respiratory epithelium of the respiratory tract to maybe a squamous type of a cancer. Right? And you can also have connective tissue metaplasia. It's not limited to the cells. And this is where you have formation of mesenchymal tissues in places where they are not normally supposed to be. Right? Then this one, there are stem cells involved, but all you need is to reprogram the stem cells to form something else. And what stimulates that? It's simply going to be growth factors again, right? Then metaplasia can be precancerous, but sometimes it's not always going to be precancerous. So it's not every metaplasia that is going to lead to cancer. Get this right. Some metaplasias can lead to cancer, that's fine, but not every metaplasia can lead to cancer. And when eventually you get to cancer, it's going to be a metaplasia, dysplasia, neoplasia sequence. You start with the metaplasia, then you go to dysplasia, which is now the abnormal growth. Then you go to neoplasia, which is now the uncontrollable, right? So not all metaplasias are going to lead to cancer, right? But most common metaplasia, it's a columnar to a squamous, which is in the respiratory epithelium, which is there is the number one there, right? Then you can think about embryology. If you once went through molecular embryology, retinoic acid, it's vital for normal epithelial growth, but deficiencies in vitamin A or retinoic acid can lead to um, certain forms of metaplasia, right? Okay. I think all these are the examples that you guys can look at and you know. Then dysplasia, there's going to be variations. We might say these are abnormal, disorganized, right? So this is going to have variations in the size and the shape and the phenotype and everything, right? So when you see, for example, here it's saying metastatic epithelium of the Barrett's esophagus can have dysplasia. This is no way we are thinking about metaplasia, dysplasia, neoplasia sequences, where now you started off with a change in the epithelium. Now there's an abnormal growth, which is now uncontrollable, which is now disorganized rather. Then you go to the uncontrollable, which is the neoplasia now. That's when you get to cancer as the endpoint. Right? I'll talk about that when I do the talk on neoplasia or cancers or oncology. Right? All those are examples. Right? And what normally leads to dysplasia is a continuous stress. Right? Okay. You can have hyperplasia going to dysplasia, then cancer again. That's another form of then neoplasia. I'd really like to talk about neoplasia in a separate talk, but it's also part of these cell adaptations, like I said earlier on. But this is now where we will think about the precancerous things, right? Okay. Then for the purpose of you guys' exams, I'm sure you talk about causes of maybe not causes of cell injury, but okay, I'll do that with the cell injuries. That's fine. Then what else can I talk about here? Cell adaptation. Okay. Right. I think that's that for cell adaptations, but the basic ones: hypertrophy, hyperplasia, atrophy, metaplasia. Then you can now think about dysplasia, neoplasia as well. Right.